I'm Dr. Jonas Swartz, and I'm here with Dr. Beverly Gray, and this is Outlawed.
So in the last episode, we heard from a patient facing a challenging diagnosis in her pregnancy, and she was able to leave her state where care was restricted and go to a state where she could get care.
We also heard from a high-risk OB doctor who sees patients who have medically complex pregnancies. In the news, we often hear many of these exceptional abortion stories, and they're heartbreaking and important, and we are really grateful for the generosity both of those guests showed us in sharing their stories. But even in states with abortion restrictions, those are the minority of cases.
The question that we often come up against is, why can we provide care with compassion in some cases, but not others? And we feel like if the world had a better understanding or a window into the world of patients seeking ordinary abortion, they might have a little bit more compassion for why they need care.
And to me, many of those cases are really compelling as well. So when I see patients who say to me, you know what, I just couldn't afford to have another kid at home, or, I have a special needs kid and I really need to be able to spend time to parent, or, I just got into nursing school and that's what I need to focus on right now. Those are really good reasons that I think people need abortions too.
Or people who say, I almost hemorrhaged and died with my last pregnancy, but that is not on the list of medical exceptions in most states for patients. So let's talk about who seeks abortion care. That's really at the heart of this episode. We're talking about who seeks care, who has access to care, and who doesn't have access to care.
Firstly, we know that the need for abortion cuts across races, it cuts across religion, and to a large extent, it does cut across socioeconomic status. So we should note there are two disparities that are important and two groups that are disproportionately represented among those who seek abortion care. The first one, and this is surprising to people, is that 6 out of 10 people who have an abortion already have kids at home. And this really counters that myth that you often hear in state legislatures or among people who are anti-abortion, that it's these irresponsible young women who are just having sex and not using contraception. I haven't met those patients yet. Most of our patients are people who are actively deciding that they want to devote their limited resources to parenting the children that they have.
Right. And, we're both parents. We have kids. We know what a commitment that is to raise a family and how expensive it is to raise a family. And so I think those people who are already parents really know what it's about.
And what capabilities they have. What bandwidth do they have to parent more kids? I will tell you, today I have zero bandwidth to parent more children. The other group the other disproportionate representation among abortion seekers or people who need abortion is that 3/4 of people are low income.
Right.
And that's really important because specifically 3/4 of people who have abortions would use Medicaid for their medical care in other circumstances. And unfortunately, Medicaid doesn't pay for abortion care.
Right. Right. And so you have people, many who are already parents, many who are living at or under the poverty level, who are struggling to make ends meet. And the insurance that covers the vast majority of those people doesn't cover their abortion care. So they have to patch together the money to be able to pay for care, seek assistance from family, friends, abortion funds, other ways to make that happen. And we see that a lot.
Yeah. And it's one other unfair thing for the person carrying the pregnancy, right? I haven't seen a lot of people with penises scrounging up or working to scrounge up that funding to get the abortion that's needed for a pregnancy that they helped cause. One positive thing that has happened after Dobbs is there is more philanthropic funding. There are abortion funds which do help patients access care and even can help patients access funding to travel or to stay in hotels or to get childcare. But that has been one big, very negative effect of Dobbs, is that you have all those other considerations because people are needing to travel. 170,000 people traveled for abortion care in 2023.
Right. So,
it's wild.
Yeah. So the year after Dobbs, 1 in 5 people seeking abortion care was having to travel to another state. And if you're in the South and you're surrounded by states that have abortion bans, you have to travel pretty far to get care. So I think on this part of the conversation, we can talk about Hurricane Helene and why I think it's a perfect analogy to the Dobbs decision.
Okay. So tell me about Hurricane Helene.
Okay, so I grew up in Western North Carolina in a little town called Marshall that's on the French Broad River, and Hurricane Helene devastated downtown Marshall. And it's interesting, like, talking to my family because they kind of live up in the holler away from the river and had no damage to their house. They got their power back in 48 hours. They, have cell phone reception now. And I saw someone talking about this phenomenon of guiltitude. Like, when I talk to my parents, they have this, like, guilt that, they really didn't have it that bad, but so many of their neighbors, like, lost their houses, lost cars, lost, like, their livelihoods. But they're also grateful that they have what they have. And I feel like, the U.S. is sort of like Western North Carolina, right? Like, there are places that are high up on the mountain, kind of looking down, being like, "Ooh, it's bad down there." Like, those poor people by the river, those poor people that were flooded, like, bless your hearts, right? But also, like, they feel guilty that, like, for the moment they're safe, and that, this devastating disaster didn't wipe them or their livelihoods or their house off the planet, but not really understanding it either, right? Like, not really getting what the people down in the valleys are, like, going through right now. And I feel like Dobbs did the same thing. Like, it sort of, like, already you had these people that were kind of on the edge and maybe, like, living in poverty, not having care, not having access, like, really devastated. Like, really, okay, now access was already like a pipe dream. Now it's like, yeah, it's not going to happen for you. And then you still have these people, like, up on the mountains that are like, okay, we can still provide care. Maybe we can make it better. We'll, like, get a generator for our house. We'll, like, do all these other things to make life better. I don't know. It just seemed like the perfect analogy to what Dobbs has done.
Yeah, you got to send people up to the holler.
I know.
So we're, like, midway down the mountain, though.
Yeah. And I feel for the people who are in systems where they can't do that. Like, I can't even imagine what that would feel like.
Yeah.
So I think even though North Carolina has this ban and we've been dealing with it, we still come from a place of privilege in that we have support. We have the ability to still provide the medical care that's right for people. It's depressing.
Today we're going to talk with two experts who helped us understand the way that people seek abortion every day.
And both of these experts are experts in reproductive justice. They're reproductive health advocates, community organizers, and they're people who have experienced pregnancy as well. And so what we're talking about today is really more than just reproductive rights. It's access to care. Because even before Dobbs, there were many people who had the right to abortion care but didn't have access to it. So we're going to be talking about what might lead a person to need care and what happens when they're denied care or receive care that's subpar or even unable to get care because it's unaffordable.
So we have two guests today. One is Maya Hart and the other is Ash Williams. So Maya's going to define reproductive justice for us and help us understand why it's so important in terms of how we contextualize abortion access and how that relates to what we were just talking about of who can and cannot access care.
And we'll also talk to Ash Williams, who is an abortion doula and is working to support patients as they seek care that they need and they deserve.
My name is Maya Hart, and I am a mother, doula, breastfeeding and lactation counselor, and a reproductive justice organizer. I have been doing this work and in these spaces for the last maybe 5 or 6 years, and just have really come to appreciate and embody, what I hope to embody, the reproductive justice framework and movement. And we define reproductive justice as the human right to bodily autonomy, to have children, to not have children, and parent the children we have in safe and sustainable communities. And I always underscore that safe and sustainable communities because that makes it clear that any issue that anyone cares about, climate justice, climate catastrophe, and policing and access to food and housing, all of those issues determine the conditions under which we are giving birth and raising children or not raising children. And so any issue that you can think about is inherently connected to reproductive justice and bodily autonomy. Being a parent has completely transformed who I am and my outlook on life and who I do this work for. You know, it's interesting since I think I've always somewhat, even as a younger person, identified as someone who thought abortion was acceptable. And now that I'm actually living parenthood and understand, and I'm someone who's always wanted to be a parent. I was very clear on that. And now that I'm in it and living it and understand just how unbelievably taxing and expensive and difficult, and I mean, it's completely transformed my life. And now that I'm in that experience, I'm even more rooted in my understanding of that everyone should get to make their own decisions about whether or not they want to parent or not.
A lot of Maya's work revolves around educating people about reproductive justice and access to care, and highlighting why a reproductive justice framework is really important for making impactful changes for the communities that are most impacted by bans. I had this moment when I was on a panel with Maya talking about the changes in North Carolina after our most recent ban that went in place in 2023. And for me, she highlighted why Roe was never enough and why it wasn't enough for the people who were most cut off from care. And I think sharing a bit of that clip is really important to understand kind of what we need to be doing in our work to provide care for the communities that are most marginalized in this space.
Can you hear me okay? Yes. Okay. I wanted to name first that, and not to downplay the seriousness of Roe being overturned, this moment is really crucial, but to be clear and making sure we're all on the same page, Roe was never enough to begin with. And if we don't center access in our conversations, then we can't even really have this conversation in a fair way, because even before Roe was overturned, abortion was inaccessible. And that was intentional. It's always been hard to access for rural folks living in rural counties, for working class poor people. It's an extremely expensive procedure. These shifts that we're now seeing with SB 20 certainly make it even more inaccessible, but I just want to make sure we're all under the same understanding that it wasn't actually even accessible for a lot of people to begin with. Most people seeking abortions are already parenting, so you have to factor in what people are doing. If they need to travel for this procedure, what are they doing with their children that they already have? That's a barrier. Most people can't afford to just take off work. You have to think about childcare, transportation, gas money, days away from home. So abortion has always been inaccessible, and this is just, further alienating and imposing violence on the bodies of women and all birthing people. I also want to name that it's not just cis women who are seeking abortion care, but also queer and trans folks and anyone who's able to be pregnant.
Maya alludes to something really important here, which is the intention of our public policy in making it difficult for some people to access abortion. Can you talk a little bit about the Hyde Amendment?
So the Hyde Amendment essentially restricts federal funding from covering abortion care unless there are certain exceptions that are met. So unless it's a case of rape or incest, risk to the life of the mother, then abortion care can't be paid for. And so
By the federal government.
By the federal government. Now, some state governments help support people who need abortion care in pregnancy, but that's only 17 states. So most states cut off care for people who have Medicaid coverage during their pregnancy, which is a disproportionate number of people who are seeking abortion care.
So the Hyde Amendment is obviously named after someone. So talk a little bit about Henry Hyde.
Henry Hyde was a representative who sought to restrict abortion care. And there's actually a quote from Henry Hyde where he talks about using this as a mechanism to restrict care. And he says, "I certainly would like to prevent, if I could legally, anybody having an abortion, a rich woman, a middle-class woman, or a poor woman," he said. Unfortunately, the only vehicle available is the Medicaid bill. And that's just alluding to the fact that restricting abortion through insurance coverage was a mechanism. And so that's what's been in place since the 1970s.
Yeah, and it's a component of every budget bill, essentially, is this Hyde Amendment, which says that that federal funding can't go toward abortion care. And it's striking when we think about, first of all, this provision that is so clearly biased from the 1970s making a huge impact on the health care that we provide today. You know, we see patients in North Carolina who generally don't have any insurance coverage for abortion care, whether they're Medicaid patients or privately insured patients. But it's so much crueler that people who are low income and can't muster outside resources to pay for their abortion care don't have insurance cared for it.
And they're disproportionately impacted by this law.
Yeah.
I want you to, if you can talk a little bit about just kind of the birth of the reproductive justice movement, just because I think that framework is really important for all abortion advocates to kind of understand that framework.
Yeah, and this will be brief and not super detailed. There's a lot more to this story, but it's important for everyone to know and understand that the term and sort of movement of reproductive justice came about in 1994 by a group of 12 Black women who recognized the ways that Black folks and Black women in particular were just completely left out and ignored in conversations around healthcare needs and access. And this language around choice didn't actually feel relevant or apply to Black women who, by nature of their race and gender identities and the intersection of those things, just don't have access to the care that we all need and deserve. And so there's been a major shift over the last few decades to move away from the language of choice and center access, because even in states and areas where abortion is legal, that doesn't mean it's accessible. Folks living in rural areas, low-income people who are disproportionately pushed out of access because of their racial identity. We have to center the lived experiences of historically oppressed people, because by nature of doing that, it includes everyone else. And so everyone is benefiting from initiatives and policies that make sure marginalized people can get access to the care that they need.
My name is Ash Williams, and my pronouns are he and him. And I am a community organizer, an abortion doula, a reproductive justice advocate. I'm also someone who is a former defendant, someone who's experienced being on probation. I'm someone who's had 2 abortions and really proud of that, and I'm happy to share my story as a Black trans person who's had an abortion before. And I'm someone who is interested in training up other people to skill up around these support and care skills to show up for abortion seekers where they are. And so I train other people to become abortion doulas to offer emotional, informational, and physical support.
In his work as an abortion doula, Ash helps people find funding, coordinate their care, and he also is an educator who helps providers learn how to better interact with patients of all sorts.
In thinking about kind of your path to that work and why that work is so critical for you, what did you see as the gap in your experience as a patient?
Yeah, so when I think about the gaps, I think about my abortion experiences, and I think about being dead named and being misgendered in the abortion clinic and not really having an opportunity to talk about my gender at a time when I thought it really mattered in terms of the care that I was receiving. I also experienced not feeling quite listened to and like heard at times when I would be talking about what was happening in my life outside of my abortion. Today, I realize and I understand that a lot of people who are having and seeking abortions, they have a lot of other things going on that they might need support around. And so that was one of the other gaps that I noticed. I also noticed this gap around funding, specifically financial support for abortion. I needed financial support, and I reached out to my local abortion fund, as well as my family and friends who I thought were supportive. And that is how I funded my abortion. And so I think it's really important to show up for people in those ways. And so the care that I provide now as a community provider, that's how I refer to myself. I am definitely thinking about those things that I didn't get, being listened to, being understood from a gendered standpoint, and then also like being provided with like holistic care around the abortion.
Yeah. People listening to this podcast will be from a variety of different backgrounds. There'll be people who've had abortions, people who may be supportive, people who maybe not, but also maybe clinicians who are part of the clinic and skill set, and that have that skill set to provide care. What are some things that people could have said to you or could have offered in that time to like gotten to know you as a person and to have seen your humanity?
I think that people could have, or the providers could have done a better job of listening to me. Something that is particular about my experience is that I had low iron. And I recall for my first abortion, I remember that the provider was considering not doing it that day. And when I learned this, I remember like feeling upset and sad because I had to wait 3 days already after I decided to have an abortion to have one. And then hearing about my iron being low, that being the first time that I heard that, like not being able to touch base with like my primary care physician about that, and then knowing that that might be something that prevented me from having the affirming procedure that I was looking to have, my procedural abortion. I was really sad about that, and I was upset about not being able to communicate with anyone about that beyond knowing that that might be true for me. And so I would have loved to have been able to check in and really hear more about that, and maybe learn about what I could do to like support my iron. I had a friend who was driving me that day because I wanted sedation, and she is the one who actually supported me with my iron after. You know, she stayed with me for 24 hours after my abortion, and she made me collard greens. And that act, really made me feel supported and listened to in ways that I wasn't able to access in the clinic. Yeah.
No, I'm sorry you had that experience.
Yeah. I also, I wanted different sedation options as well. The clinic that I went to, the only thing that they provided was Ativan. And as someone who uses Ativan for other instances of my life, I was a little thrown off by that, and I wondered about what the other options were. I was also saddened that like the sedation that would have made that did make my procedure more accessible, it cost me more money. And so it makes me think about the people who are not able to have the type of abortions that they want to have because of these barriers like money or not having a ride, and things like that. And so all of these things really inform the ways that I show up as a doula.
So we've both been in clinics where we're seeing, many patients throughout the day, and some patients do receive a new diagnosis of anemia. Can you talk a little bit about kind of how that comes about and how we manage that?
Yeah, Ash mentions that his iron was low, and iron does connect directly to your hemoglobin stores. And oftentimes your hemoglobin and hematocrit, so a measure of anemia, is one of the only lab tests that you'll get as part of an abortion to make sure that it's safe for you to have care that day. And it can be a limiting factor because if you're in an outpatient clinic where you can't give a transfusion, if someone had heavy bleeding and is already on the anemic spectrum, that may be more dangerous for that person. And we want to make sure that, care in outpatient clinics is really safe already. But part of the way that we keep that care safe is by making sure that the right individuals are getting care at the right time.
Right. And so we screen patients' medical histories. We get the screening test to check for anemia. And anemia is a common experience that people have, or a common condition that people have in pregnancy, that we often identify in early pregnancy, and there are, ways to treat that. But, care is very siloed in abortion care, and so many patients are seeking care in outpatient centers. And so those centers are sometimes having to transfer those patients to hospital-based care, which can be much more costly for patients.
And Ash mentions that he would have liked to talk with his primary care physician about having low iron or about being anemic. And, that's a great point, right? I mean, this is a chronic condition, and it's something that you would like to be able to engage with a primary care physician. That's the perfect person to talk to about it. And part of the problem with the system is that because care is so siloed, that sometimes you don't have an opportunity to do that for patients and to sort of help them understand their diagnosis and treat it. And it would be really distressing when you need care to feel like that is a barrier, a problem that you can't fix in one day, to your access to getting that critical care on that day.
And there have been so many times where we're caring for patients who have traveled 8, 10, 12 hours to our clinic, only to receive a new diagnosis of severe anemia and to hear the news that they can't get care that day. And that's distressing for patients. It's distressing for us. And I completely agree with Ash that there are ways that we as healthcare providers can better care for people. And so I think Ash is going to talk a little bit more about educating providers, but I think that's part of making care and access better for everyone.
The other thing Ash mentions is being misgendered and dead named in the clinic. Can you define those terms for us?
Right. So individuals who are non-binary or trans may have different pronouns than what is on their birth certificate. And I think when you are a patient entering a clinical space and someone doesn't use your right pronouns or your right name, it's very jarring. I mean, you're often called the wrong name. People want to call you Jonah all the time.
Yeah, Jonah, Schwartz, Schwarz, all the time.
All the time. And it feels like nails on a chalkboard, right? And so if you are a trans or non-binary individual, and this happens all day, every day, and then it happens in a space where someone's supposed to be caring for you, it's just unacceptable. And so Ash talks about that, so being misgendered, but also being dead named. And so for trans and non-binary individuals who have a different name, their legal name on their insurance card or on their driver's license may be different than the name that's their name. And so there are ways to prevent that from happening so that people feel seen and that their humanity is seen in the clinic.
And as a trans person, when I think about interacting like with the medical industrial complex, I think about the other times where I definitely felt more empowered to like share my name, share my pronouns, and talk to providers and medical staff about how I wanted to be interacted with. And there was something unique about my abortion experience where I didn't know if it was going to be okay. When it came to the iron, I remember thinking like, oh boy, if I tell them that my pronouns are they and them and that my name is Ash, this might rule me out from having an abortion. They're already telling me that I might not be able to have it today based on the iron. And when I look back on my experience, I definitely wonder like, why was I feeling so stigmatized in that moment, right? But also that would have been a moment for me to like really be sitting and standing in my power and letting people know like how I wanted to be interacted with. And I'm sad in ways that I wasn't able to do that today. But I also think, I think, Bev, about my second abortion when I did feel affirmed enough and I felt like it would be okay if I said my name and pronouns. And I just want to name that in that moment, even though I was able to do something different, it did not matter. It didn't matter that I could say what my name was and what my pronouns were, and that I knew that I could also expect for the staff to honor me in that way. It didn't matter because they didn't do it. They didn't do it. Years later, I was able to return to the clinic that I had 2 abortions at and do a gender justice training for the staff. And it was really amazing to like reconnect with them, to like put myself in front of them as like, you all interacted with me as a trans person. I'm definitely not the only one who has been here to have an abortion. And I really care about other people's experiences, and I know y'all do too. Yeah. And so I was able to be heard in a different way, and it was really amazing and sweet. But I've had a transformative time with like my personal favorite local abortion clinic. And so I love that experience that I've had. And I also use that to like support other clinics with just maybe switching up the way that they're doing things to allow more people to access care there.
Yeah, I think that's a really beautiful gift that you could give them, that you didn't have to give them, but you totally gave them this gift that will help other people, which is really awesome. One last complicating factor is the stigma of being a Southerner and being in the South or in the Bible Belt, both as a provider and as a patient. I asked Maya about her perhaps conflicting feelings about being a Southerner and a reproductive justice advocate. I'm curious kind of how you feel about being in the South doing this work, and like, I don't know, like I feel like some people are like, well, why don't you just leave the South? And it's like, well, that's not an option.
No. It's a horrible idea.
Yeah.
I think the South gets blamed for a lot of things, or people are like, just leave. But I'm really honored and grateful to be doing the work in the South. I think the South holds this like beautiful actual legacy of resistance dating back to slavery and beyond. And, you know, the majority of Black people in the state are in the South and in the Southeast, I believe. Yeah. And so I think it's like a racist theory and idea that the South is a bad place, we should just leave and abandon it. And actually it's like our duty as people from this area, connected to this area, however you are connected to this part of the country. I actually think we're part of this really beautiful lineage of people that have been doing this resistance work for centuries. And I think that in and of itself is a reason to stay here and to keep doing it. I think when I envision, like, close my eyes and try to actually feel in my body what it would mean to have achieved reproductive freedom, I think about safety is always the thing that comes to mind. And what would be possible, again, because reproductive freedom is not solely about birth and abortion, but what would be possible if undocumented families, if Black families, if queer and trans families felt safe and felt confident that when they sent their children to school that day that they were going to come back safely, and that we weren't afraid about our children dying in schools or people dying in birth. Like, imagine how much more emotional and like mental safety and capacity we would all have if safety and security was just understood. Like, you just weren't even thinking about it. Yeah. It was just by default we had access to what we needed, and we knew our neighbors, we knew people had our backs. I just think about like how well we would be as people in ways that we can't even begin to understand right now because of all the fear of violence and criminalization. That's a very real fear.
Opinions expressed on this podcast are our own. Philanthropy is helping us highlight these stories, and we hope you'll continue to support this work by subscribing and sharing the show and getting involved in your local community. You can find us on Substack at outlawed.substack.com. Jonas, that includes you. You should subscribe to the Substack today.
It's apparently a good way to get information. This podcast is executive produced by us, Dr. Beverly Gray and Dr. Jonas Swartz, and Jane Marie. Production by Little Everywhere. Thanks to Nick Thornburn and Maker and Patrick Ford for our score, and Jamal Walton for original artwork. Extra special thanks to everyone who lent their knowledge and voices to the show.
On the next episode, you'll be hearing from Dr. Caitlin Bernard, who is one of the bravest physicians I know. She tells us her story about what it's like being a physician providing excellent care, yet being targeted by the local authorities.